Most people never question a surgeon's recommendation. They assume the doctor is right, the hospital is ready, and all they need to do is sign the form. I believed that myself for years, until I started paying attention to what happened after the surgery. Not during, after. A man came in with persistent back pain. He could walk, he could drive, he could sit through dinner with his family. He went in for what he was told would be a straightforward spinal procedure. He came out unable to stand on his own. Not temporarily, permanently. A woman in her early 70s agreed to cardiac surgery after being told it was her best option. She survived the operation, but spent the next 8 months battling one complication after another: infections, kidney problems, confusion that never fully cleared. She went in hoping for more years. She lost most of a year just trying to recover. These are not rare stories. They are far more common than the medical world wants to acknowledge. My name is Dr. Andrew Collins. I have spent over 20 years as a cardiothoracic surgeon. I have performed thousands of operations. I have saved lives on the table, and I have watched lives slip away on the table. And today, I want to share with you what I have learned about 5 specific surgeries that carry hidden dangers for anyone over the age of 60. Not to scare you, but to prepare you. Because preparation is the one thing that can genuinely change your outcome. Let me start with something simple. Imagine 2 bridges. One was built 5 years ago with modern materials. The other was built 40 years ago and has carried heavy traffic every single day since. Now imagine putting the same massive load on both bridges at the same time. Would you expect them to hold up equally? Nobody would. And yet, for a very long time, that is exactly how medicine approached surgery in older adults. The same procedures, the same anesthesia protocols, the same recovery plans that worked for a 45-year-old were applied without hesitation to a 75-year-old. That thinking is slowly shifting, but I can tell you from the inside, it has not shifted nearly fast enough. Here is what actually happens inside an aging body when it undergoes general anesthesia. The cardiovascular system has to compensate far more aggressively. The lungs, which may already have reduced capacity, struggle to clear the anesthetic agents. The kidneys, responsible for filtering every medication pumped into the body, work slower and sometimes falter under the load. And then there is the brain. This is the one nobody warns you about. After major surgery under general anesthesia, a significant number of patients over 70 experience something called postoperative cognitive decline. It is not just grogginess. It is a measurable drop in memory, focus, and mental clarity that can persist for weeks, months, and in some cases, it never fully reverses. Studies have documented this extensively, yet most patients are never told about it before they agree to an operation. Now, I want to be very careful here because I am not saying that age alone should keep someone out of the operating room. That would be irresponsible. I have operated on 82-year-olds who recovered faster than patients half their age. Chronological age is a number on a chart. What actually matters is something called physiological reserve, the body's ability to absorb a major shock and bounce back. Another word for a low reserve is frailty. Frailty is not about looking weak or being thin. It is a clinical measurement. It means the body's systems are running with very little margin. Approximately 4 out of 10 people over 75 meet clinical criteria for frailty. That number climbs sharply past 85. So the critical question is never simply can this person survive the operation. It is can this person survive what comes after the operation. The surgery itself might last 3 hours. Recovery demands weeks or months of sustained effort from every organ in the body. And that distinction between surviving the procedure and surviving the aftermath is going to be essential as we go through these 5 surgeries. The first surgery I want to discuss is open heart surgery in patients who are already medically fragile. Coronary artery bypass grafting is one of the most frequently performed major operations on older adults. The concept is straightforward. Blood vessels supplying the heart are blocked, so we create new pathways for blood to flow. When it works, it genuinely extends lives. But here is what you are rarely told about what the procedure actually demands from the body. During open heart surgery, we stop the heart completely. A machine takes over the job of circulating blood and oxygenating it. That machine, while extraordinary, is not gentle. It triggers inflammation throughout the entire body. It puts stress on the kidneys, the brain, the lungs, all at once. For a relatively healthy 60-year-old, the body absorbs that stress and recovers. For a 79-year-old who already has compromised kidney function, borderline diabetes, or early cognitive changes, that machine becomes a full-body assault. Research published in major cardiovascular journals shows that in elderly patients classified as frail, major cardiac surgery carries a complication rate between 30 and 45%. These are not minor complications. We are talking about strokes, kidney failure requiring dialysis, prolonged mechanical ventilation, and severe confusion lasting weeks. And in the highest risk group, roughly 1 in 7 patients does not survive the first month after surgery. So what else is available? In many situations today, there are catheter-based cardiac procedures that accomplish similar goals without ever opening the chest or stopping the heart. A thin tube is threaded through a blood vessel, and the repair is made from the inside. The recovery is dramatically shorter. The stress on the body is dramatically lower. These options are not appropriate for every patient, but they are appropriate for far more patients than currently receive them. The single most important question you can ask your cardiologist or cardiac surgeon is this: for someone with my exact health profile, is there a less invasive way to achieve this result? That question alone could redirect your entire treatment path. The second surgery is extensive spinal surgery for chronic back pain. If you are over 65, you almost certainly know what chronic back pain feels like. It is one of the most common complaints I hear from patients, even those who come to see me for heart issues. And increasingly, the solution being offered is surgical, multi-level spinal fusions, titanium rods and screws anchoring sections of the spine together, complex decompressions involving multiple vertebrae. Let me be very direct. There are genuine spinal emergencies where surgery is not optional. When the spinal cord is being compressed and someone is losing control of their legs or their bladder, surgery is necessary and urgent. That is not what I am talking about. I am talking about elective spinal fusion for the kind of degenerative back pain that develops naturally with age. For this category of patient, the evidence is deeply concerning. A comprehensive analysis published in a leading orthopedic journal found that in patients over 65, complex spinal fusion procedures had complication rates above 40%. The most frequent problems included surgical site infections, blood clots, failure of the implanted hardware, and a condition where the segments of spine above and below the fused section begin to deteriorate more rapidly because they are now absorbing forces the fused segment no longer handles. The surgery fixes one area and accelerates damage in the adjacent areas. And here is what is most frustrating. When researchers compared outcomes over 2 to 5 years, patients who underwent aggressive spinal surgery for degenerative pain reported no greater improvement than patients who pursued structured physical therapy, targeted steroid injections, and lifestyle modifications. The same level of relief without the surgical risk. A mentor of mine, a deeply experienced orthopedic surgeon, once told me something I have carried with me for years. He said, "Andrew, the most skillful thing a surgeon can sometimes do is recognize when the knife is not the answer. That takes more courage than operating." If you have ever been told that surgery is your only option for chronic back pain, I genuinely want to hear about it. Share your experience in the comments. You may find you are far from alone. The third surgery is radical cancer surgery in elderly patients with significant existing health problems. This is the most emotionally charged topic on this list, and I approach it with great care. A cancer diagnosis triggers an overwhelming and completely understandable response. Remove it. Get it out. Do whatever it takes. I would feel the same instinct myself. But 20 years of surgical experience has taught me something that is difficult to say and even more difficult to hear. The purpose of cancer treatment is not simply to eliminate the tumor. The purpose is to give the patient more meaningful time, more months or years where life has quality, where there is presence, comfort, connection, and in some cases, not all, but some, major cancer surgery in a frail elderly patient does not add meaningful time. It subtracts it. Consider one of the most demanding operations in surgery, a procedure to remove pancreatic tumors that involves taking out portions of several organs simultaneously. In a fit 55-year-old, this operation can be genuinely curative. But in an 81-year-old with existing heart disease and declining kidney function, the surgery may technically succeed, the tumor is removed, and yet the patient never recovers. They spend their remaining weeks or months in an intensive care unit battling complications from the operation itself, not from the cancer. There is a term in surgical literature for this. It is called futile intervention. A major registry study found that approximately 1 in 5 elderly cancer patients who underwent aggressive surgical resection experienced what is known as failure to rescue, a complication that the body simply could not overcome. These patients did not die of cancer. They died of surgery. So what is the alternative conversation? Ask your oncologist to explain clearly and honestly what happens if surgery is not performed. What do radiation therapy, chemotherapy, immunotherapy, or carefully monitored watchful waiting look like for someone with your specific age and health profile? In many cases, these alternatives offer comparable survival time with vastly better quality of life during that time. This is not giving up. This is making a fully informed decision about how you want to live. The fourth surgery is planned joint replacement in patients carrying multiple serious medical conditions. Let me say something first that I believe completely. Hip and knee replacement surgery, when performed on the right patient at the right time, is one of the greatest achievements in modern medicine. I have watched people go from being trapped in a chair by pain to walking through a park with their families. It is genuinely transformative. But the words right patient and right time carry enormous weight, especially for someone over 75 who is managing several chronic conditions simultaneously. When a patient with heart disease, poorly controlled diabetes, chronic kidney impairment, and significant excess weight undergoes elective joint replacement, the risk profile changes substantially. Blood clots are the primary concern. The combination of surgical trauma, reduced mobility during recovery, and pre-existing circulation problems creates conditions where clots can form in the deep veins of the legs and travel to the lungs. A pulmonary embolism in an elderly patient with compromised cardiovascular health can be fatal. Beyond clots, there is the risk of post-surgical pneumonia from reduced breathing capacity while immobilized, hospital-acquired infections that an already stressed immune system struggles to fight, and cardiac events triggered by the physiological stress of surgery and anesthesia. I do not want anyone to hear this and conclude they should never consider joint replacement. That is not my message. My message is about timing and preparation. There is a concept in surgery called prehabilitation, actively improving your physical condition before a planned operation, controlling blood sugar, bringing blood pressure into optimal range, losing weight if possible, building muscle strength and cardiovascular endurance through supervised exercise programs. Some of the best surgical centers now require weeks of prehabilitation before they will schedule an elective joint replacement for a high-risk patient. The data supporting this approach is compelling. Patients who undergo structured preparation before surgery have measurably lower complication rates and significantly faster recoveries. Has anyone ever discussed prehabilitation with you before a planned surgery? Most patients have never even encountered that word, and it could be one of the most important concepts in their entire treatment journey. The fifth surgery is emergency abdominal surgery. This one is fundamentally different from the others because you do not plan for it. You do not choose it. A ruptured appendix, a perforated section of bowel, sudden internal bleeding, these situations arrive without warning and demand immediate action. But here is precisely why I included on this list. Understanding the risks before the emergency occurs changes how you and your family respond when it does. Emergency abdominal surgery in patients over 75 carries some of the highest mortality figures in all of surgical medicine. In the most severe presentations, the 30-day mortality rate ranges from 30 to 50%. This is not a reflection of surgical failure. It is a reflection of the extraordinary demands that emergency surgery places on an already aging body. When the abdomen is opened under crisis conditions, every organ system is affected simultaneously. The immune response, which in a younger person mobilizes efficiently and then resolves, can become uncontrolled in an elderly patient, triggering a cascading failure across multiple organ systems. So what can you actually do with this knowledge? Two things, both of them practical and both of them within your control right now. First, do not dismiss persistent abdominal symptoms. Pain that does not resolve, unexplained changes in digestion or bowel function, bloating that worsens over time. In someone over 60, these symptoms warrant prompt medical evaluation, not next month, soon. Catching a problem when it is manageable prevents it from becoming a crisis that requires emergency surgery. That single habit of taking symptoms seriously and seeking evaluation early is one of the most powerful protective actions you can take. Second, have the conversation with your family now. Not in the waiting room at 2 in the morning while a surgeon is asking for consent. Now, while everyone is calm, clear-headed, and able to think carefully. What are your wishes if emergency surgery becomes the only option? What does quality of life mean to you personally? What outcomes would you find acceptable, and which would you not? These conversations are not morbid. They are not pessimistic. They are among the most loving and generous things you can do for the people who care about you. Because in that moment of crisis, they will not have to guess what you would want. They will know. Now let me bring all of this together with something practical you can carry with you. Before any major surgery, whether planned or recommended, there are 4 questions that every patient over 60 should ask. And I would encourage you to write these down or save this part of the discussion, because these 4 questions have the potential to fundamentally alter your medical experience. Question 1. What happens if I choose not to have this surgery right now? A skilled and honest surgeon will give you a direct answer. If the truthful answer is that nothing critical changes in the next several months, then you have time. Time to research, time to prepare your body, time to get a second opinion. Question 2. Is there a less invasive approach that could achieve a similar outcome? The landscape of medical procedures has changed dramatically in the last 15 years. Robotic-assisted techniques, endoscopic procedures, catheter-based interventions. Options that did not exist a decade ago are now available in most major medical centers. But you may not be offered them unless you ask. Question 3. What does recovery realistically look like for someone with my specific health conditions, my age, my current medications, and my living situation? Not for the average patient. For me. The answer should be detailed and specific to your circumstances. Question 4. What is your personal complication rate for this procedure in patients in my age group? Every experienced surgeon tracks their outcomes. They know their numbers. A confident, transparent surgeon will share that information willingly. If the question is met with evasion or discomfort, that response tells you something important. Before I close, I want to tell you about a patient I will call Robert, 73 years old, retired high school teacher, mind like a steel trap. He was referred to me after 2 separate cardiologists recommended open-heart surgery for a severely narrowed coronary artery. Both recommendations were made by excellent physicians with genuine concern for his health. Robert was not afraid of surgery. He had been through difficult things before. What concerned him was something he had witnessed firsthand. His older brother had undergone a major cardiac procedure 3 years earlier. His brother survived the operation but was never the same afterward. The confusion, the fatigue, the loss of independence, it had changed him fundamentally. Robert told me during our first meeting, "Dr. Collins, my brother went into that hospital as a man who built furniture in his garage and told stories that made everyone laugh. He came out as someone who needed help getting dressed in the morning. I do not want that to be my story." I spent a full consultation with Robert, much longer than the standard appointment. We reviewed every aspect of his health, his kidney function, his cognitive baseline testing, his cardiovascular fitness, his nutritional status. And I told him the truth, plainly and completely. Surgery was one valid option. But given his specific profile, an intensive medication regimen combined with a structured cardiac rehabilitation program offered comparable projected outcomes over a 5-year period, with significantly lower risk of the complications he feared most. Robert chose the non-surgical path. That was nearly 4 years ago. 2 months ago, I received a message from him with a photograph attached. He is standing in his garage next to a rocking chair he built from scratch for his first great-grandchild. He is smiling in a way that tells you everything you need to know. Here is what I need you to carry away from this entire conversation. This is the single most important thing I will say. A surgeon's recommendation is not a final verdict. It is the opening of a dialogue. You are not a passive participant in your medical care. You are the central decision maker. From the moment you enter a doctor's office, you have the absolute right to ask every difficult question, to explore every alternative, to seek additional opinions, and to take whatever time you need to make a decision that aligns with your values and your life. The surgeon holds the instrument. You hold the authority, and that authority, exercised with full information and clear understanding, is more powerful than any procedure I have ever performed. Let me summarize what we have covered. 5 surgeries that carry significant underappreciated risks for people over 60. Major cardiac surgery in fragile patients, where less invasive catheter-based alternatives now exist and continue to improve. Extensive spinal fusion for chronic degenerative pain, where the evidence for surgical superiority over conservative treatment is far weaker than most patients are led to believe. Aggressive cancer resections in elderly patients with serious coexisting conditions, where the goal must always remain more good life and not simply more treatment. Elective joint replacement in patients managing multiple chronic illnesses, where proper timing and pre-surgical preparation can make the difference between transformation and catastrophe. An emergency abdominal surgery, where the greatest protection comes from early attention to symptoms and honest, advanced conversations with those you love. None of this is a call to reject surgery. Surgery remains one of the most powerful tools in medicine. It saves lives every single day, and I am proud to be part of that work. What I am asking you to do is simpler and more important than that. Be informed, be engaged, be willing to ask the question that feels uncomfortable. Seek a second perspective, and if something does not feel right, seek a third. Your instincts about your own body deserve respect, including from your medical team. What question would you most want to ask your surgeon before a major procedure? Tell me in the comments. I read every response, and they shape what I discuss next. And if this conversation helped you or someone in your life think more clearly about a medical decision, send it to them. That single action might be the most meaningful thing you do this week. Take care of yourselves. Stay curious about your own health. Keep demanding honest answers. You deserve a physician who explains everything clearly and a medical team that treats you as a full partner in every decision. And one final note. Everything I have shared today reflects general medical knowledge drawn from published clinical research and 2 decades of personal surgical experience. Every individual's medical situation is unique. Before making any decision about surgery or treatment, please have a thorough, honest, unhurried conversation with your own physician or specialist. They understand your history, your body, and your specific circumstances. And that conversation, conducted with openness and mutual respect, is exactly where the best medicine begins.